Thanks everybody for staying here, and thanks for the panelists to join me. So basically, we're going to be talking a little bit about perhaps changing a little bit the subject. So far, we have talked a lot about healthy aging in terms of policy, in terms of public health, and other aspects. We have covered the whole area, really. Most recently about investments, about biotechs, etc. So all of this is possible because of advances in what we know about the basic biology of aging. And that is what has allowed us to build this ecosystem that we have been talking about. So basically, we're going to be talking a bit about that and how aging biology has evolved during the last couple of decades. Just a little side aside, I joined the field of aging biology about 3 decades ago or something like that. And the reason I joined, to be honest, was because it was so backwards that I felt I could make a difference, because it was really backwaters science. That's no longer the case. These days, aging biology is at the center of a lot of research. And that allowed the development of concepts such as geroscience, which was something that Eric and Debak, as well as myself at the NIA, were developed a decade ago or so. So a lot has happened in that area. Now, what's important, in my opinion, is that all of these advances have allowed us to come to the place where we are now, with an ecosystem that's robust, where we're on the verge of producing something that helps human healthy aging. But it's important to continue on this direction, because if we don't continue funding and doing basic research and continue doing geroscience, the pipeline will dry. So it's very important that we continue going this. So I would like to start the panel discussion with basically, if you guys can tell me what has changed in the field during the last 10, 20 years. What are the most important things that have happened? And maybe at the same time, or maybe we'll do a separate, what do you think is the next? Okay, can we start with you, Eric?
Yes, thank you, Felipe. Delighted to be here for this event. I must say that I'm really impressed by the whole event that's been organized. It's been a pleasure to be here and to see the science coming to reality. So I think one of the key thing that has happened, if you look at the life cycle of discoveries in biology and their translation to medicine, is that we are at that phase where we are taking all of this basic knowledge and bringing it to the clinic. And so this is why this meeting is so timely in terms of having it now. The field is entering a new stage in which we understand aging better, far from understanding it completely, but where we can start envisaging bringing these discoveries to the clinic. And I think we see this here, we see this across the world, and could not be more excited about the potential that lies there to bring all of this basic knowledge to helping humans actually live better longer.
But in your opinion, what has been the most exciting thing that happened in the last? I mean, I know a lot of exciting things has happened. So what would be your favorite?
My favorite is this idea that 20 years ago, we thought of aging as a random stochastic process, sort of falling apart. I always use the analogy of a wall of bricks, where one brick falls off, another falls off, and then eventually 3 bricks fall off, and you have a hole, and eventually the whole wall collapses. That was our vision of aging, stochastic, right, yes, random. What has happened is the realization that there are dials that we can tune, and by tuning them, you can actually regulate the rate of aging, either to accelerate or to slow it down. And in many ways, the analogy of this is to think about the wall model, but to think about a mason behind. So even though the wall is falling apart, the forces that induce the aging process exist. We have embedded in our organism, us and all life forms, mechanism of repair and maintenance. And these mechanisms are what we're trying to trigger to delay the aging process. So I think the idea that aging is tunable is actually extraordinary. And frankly, at first, when this was discovered, we thought this was the exception. But it turns out today, when we study a little worm, we have more than 700 genes that we can regulate that actually increase lifespan. So that just speaks to the potential of all the targets that we have in the future.
Thanks. Jim, what's your favorite thing that has changed during this time?
I think there are a lot of things. I wouldn't pick one favorite. I started off as a clinical geriatrician, and I got tired of prescribing better wheelchairs, walkers, and incontinence devices. Went back to school, studied some basic biology to see if there's something more fundamental we can do about the issue. And so I think the field went through a long period of description. Then interventions were discovered at first in yeast and invertebrates. They made their way up through the mammals. And now we're at the point, as Eric mentioned, of translating some of these interventions that can affect health span from animal models and human cell culture and explant models into people. So this is the so-called valley of death. It's a very, very difficult bridge to cross. I've found that the aging field, on the one hand, I'm a clinical geriatrician. On the other hand, I'm a basic biologist. We were talking before, I'm also an endocrinologist. The average endocrinologist can walk from the clinic to a laboratory and do a PCR reaction. There are very few geriatricians in the world who understand or appreciate basic biology of aging and the converse. So I think there's a lot of work that needs to be done, most importantly, on coming up with new interventions and fueling the pipeline in the first place. But I think we're going to have to do a lot more work on late-stage preclinical work with a view to getting things across the valley of death and into early-phase clinical trials. There are very few people in the world who can do this, so I think this is an area we're going to have to focus on.
Thanks. So Saleh, you're not as deeply ingrained into aging biology or geroscience. So what's your feel? What attracts you to be at this panel right now?
Thank you, Felipe, and I'd like to thank actually Hevolution, Kmark, for organizing this event. I think this is really an eye-opener, and it will shape the way that not only investigate medicine, but also build how the way that we'll practice the future medicine. Now, as mentioned by you, Felipe, that I'm a scientist not involved in geroscience or healthy longevity, but actually, since I get involved, and we have that round of call for proposal at Kings Saud University, where many proposals have been submitted, I think that we are having more attention and more interest for many people and young investigator and also deep scientists about the field of geroscience. And why is this? Actually, because it is looking at science and medicine from a paradigm shift, not focusing on disease-centered, but also on healthy longevity. And clearly that what we have learned over the last few decades, definitely, that the one common factor and common risk factor for most of the chronic diseases is aging. And the lesson that we have learned recently from the pandemic of COVID-19 is actually we know that aging can drive chronic diseases, and we know that it can have functional decline. But what COVID-19 have told us also that the loss of resilience for aging is the most critical factor for mortality. And the one major risk factor for having mortality, as has been mentioned by many speakers, and the keynote speech nicely given by Mahmoud, that the one risk factor that can cause mortality for COVID-19 patient is aging, old age, above 70 years of old. So why is that? Because there is loss of adaptation, loss of resilience to accommodate for these hits. And not only limited to COVID-19, but this is the same case for influenza and for many other acute illnesses and infection. Therefore, this is something that we have learned, that looking at neuroscience in terms of the paradigm shift from disease-centered into healthy longevity, because if we work on the healthy longevity, we'll be able to help how can we have people healthier, can they live longer and healthier, and they can really have more functionality and free of chronic diseases. The other point, I think that the great work and high dedication from the many speakers and even the panelists about their work over the last few decades, 2 decades, on experimenting in mice the hallmark pillar of aging and what really can drive aging. That was really great achievement. However, that probably what we need to know and to work on is mainly take it to another level where that we can really investigate the clinical trial in humans, and not necessary to ask, for example, or work for survival studies, because that mean will take years of investigation to be able to examine these biomarkers.
So, since you mentioned the biomarker, the hallmarks or pillars of aging, I would like to know what the panel thinks about. So those were, those 2 seminal papers were published about 10 years ago. And a new version of the hallmarks was published very recently. But that should not be the whole thing. We don't, as Eric, as you said, we don't know everything yet. There's a lot more to be learned. So what areas of science do you think, maybe we could ask with you, Jim, what areas of science you think are the ones that are going to be most important in the next 10 years? What's going to be in the hallmarks of aging in 2032?
Well, I think all these hallmarks or pillars, however you slice and dice them, are tightly interlinked. I think if you target one, you tend to affect all the rest, and quite often in the same direction. But I think it's going to be important to know which fundamental aging process to target when in the lifespan and in the context of an individual patient. So I think that's where these gerodiagnostics, people call them biomarkers, I prefer to call them gerodiagnostics, are going to be important. So we're going to have to know, for example, when would you use a particular agent, be it a natural product, a repurposed drug, a new chemical entity, or a lifestyle intervention? When would you use it in a particular individual? And for that, we need to develop gerodiagnostics. I think that's going to take, already a lot of work is underway. There are going to be composite scores most likely, and the most useful gerodiagnostics aren't going to be biological clocks. They're going to be things that change that respond to interventions and predict, if they do change, predict clinical changes and responses.
So when you talk about this diagnostics, you're talking at the molecular level, at the physiological level, at a mix between the two. What do you envision will be what happens when I don't call them patients, by the way, when an individual, because they're not sick, we're talking about healthy people. So when an individual comes to a clinic to assess its level of health, what do you envision? It's going to be mostly molecular, mostly physiological, mostly intellectual? What's going to be the best?
Well, at this point, I do call them patients because most of the trials that we have underway,
the trials, yes, I agree,
are in people with serious age-related conditions, and they could be age-related conditions in children. I mean, we're doing trials with St. Jude Children's Cancer Hospital because aging occurs throughout the lifespan. These fundamental aging processes are root cause contributors to conditions throughout the lifespan. So we're starting off because of risk-benefit ratios with very serious conditions because we don't know the downsides yet of some of these interventions.
Yeah. But
when we come to prevention, that'll be in, and we're not dealing with patients anymore, that's going to be further down the road.
Yeah,
once we
I agree with that. But I prefer not to use the word patient because the goal is to do it on healthy people. But my question was, what do you envision will be the gerodiagnostics that you're going to need?
I think there'll be composite scores of all the things you mentioned. I think there'll be composite scores of things in body fluids that can be measured, of imaging procedures, wearable devices, questionnaires, data from the history and physical examination. And I think the most useful things look like they're going to be composite scores, and that may be a way of predicting which intervention to use and when. And I'm not just talking about drug interventions, I'm talking about lifestyle interventions as well, how to sequence them. And then in the case of disease states, which intervention targeting a fundamental aging process should be used also maybe in conjunction with a disease-specific intervention, especially for fibrotic diseases. I think they'll be the first. And I think in Saudi, one of the huge problems is heart failure called HFpEF. This is a leading cause of death of Saudi men, in addition to atherosclerotic heart failure. There is no good treatment for it, and it's looking like, and I think this would affect Saudi, where this is the leading cause of death of men, will be combinations of gerotherapeutic interventions with antifibrotic interventions.
Makes sense.
And animal studies are beginning to point us in that direction.
So, Eric, what do you see as the next 10 years of aging biology research?
I think it's a great question. I think if you look back at what we have done in the last 40 to 50 years, both in medicine and in biology, is examining those processes through the lens of a somewhat reductionist model. We go see a heart doctor, we see a lung doctor. That's in medicine. In terms of the biology, we study one protein or two proteins and their effect on the aging process. I think the technology has advanced at such a level in the science of aging that we need to move to the next step, which is to understand biology in its complexity. And we have a number of tools that are currently revolutionizing biology, and I'm thinking of all the omics, proteomics, metabolomics, single-cell transcriptomics, and the list goes on, where we can actually interrogate thousands of different variables. When you combine this with artificial intelligence, we can start looking not at the individual effect of single proteins, but at network effects. And complexity emerges, but also simplicity. I'll give you an example of the TOR pathway, which is a single protein which is present in multiple tissues. Its target of rapamycin, is a drug that actually delays aging, and it does so at the level of multiple tissues. So I think in some way, we have right now a return to physiology, which is the understanding of complex living system. And I think this is where I see biology and medicine going in the future, is really using a highly complex data set to interrogate the aging process. What is aging at the organismal level, at multicellular, multi-protein level, and can we identify targets and how they work in this context? I think to me that's the major challenge that we're faced with. Challenge, but also opportunities.
So, Jim, I would like to come back to the issue of the clinical trials are done indeed with in disease cases, and yet what we're interested in is in healthy aging. So, and I completely understand why the clinical trials have to be with patients on specific diseases. What do you see as a potential for eventually doing clinical trials on completely healthy people? We have a lot of geroprotectors that have been described, some in more detail, some less detail, but we have quite a number. As I said at the beginning, we need to continue doing basic research so that we can identify more of them. But how do you foresee doing clinical trials on healthy people? Will that ever be possible? Will that be productive?
It may be possible at some point. I think you have to start with people with serious disorders if you don't know the downsides, with treatment and alleviation.
Yeah, you have to start with those.
There are secondary prevention trials being envisaged, like the TAME trial, which is a secondary prevention trial. So it's people with one serious age-related condition trying to delay the time to the next one. But I think even with lifestyle interventions, you have to be very careful about prevention trials in completely healthy elderly individuals because, as a physician, you take the Hippocratic Oath. It's in Latin, even though it's written in Greek. And the first line of it is, "Primum non nocere," first do no harm.
Yeah.
And most regulatory agencies take that very seriously. So doing prevention trials will be tricky. until we've done trials in diseases and secondary prevention trials, until we have gerodiagnostics where we have surrogate outcomes that we can measure that are reasonable. And then we can start thinking about interventions in completely healthy individuals. The things that we can do for completely healthy individuals now are things like stopping smoking and other public health kinds of things.
So basically the bottom line is that the urgent thing to do is develop the gerodiagnostics so that we can do something in people who, based on those gerodiagnostics, we can predict that they are at risk of developing something. They're still healthy, but they are very high risk.
And there are trials beginning like that with relatives of type 2 diabetics. There's a trial about to begin in Sweden, and the age-related conditions, frailty and so forth that develop there. And there are going to be opportunities in other areas too that we haven't really discussed as much here. It came up a bit, and that's regenerative medicine. So will it be possible to take organs from older donors that are currently thrown away? We're throwing away 35,000 kidneys a year in the US alone because they're from people who die in car crashes over the age of 50. Can we, while they're on a life port system going between the donor and the recipient, use gerotherapeutics to try to rehabilitate that organ so it can be transplanted into a recipient?
Yes. So, Saleh, how do you see the future of aging research?
I think the work have been done all the time for elderly. Probably we know that the aging start early on.
Yeah.
Being pediatrician, this is my profession. I think the research need to focus at very early age group because we know many aging process start very early, and probably this is something that we need to have focus and attention about. And the other point that have been mentioned about the clinic, having aggregation of data, including the conventional biomarkers, as well as also different biological, as well as also digital. Let me share with you some initiative that I have been having the privilege to be called for, which was under NEOM. NEOM is establishing a huge platform, which is looking at individual population health, where they will aggregate so many clinical data, even for healthy individual. Plus also they will they will aggregate and add to that platform some of the dietary habit, physical exercise, and they will develop in their platform a different healthy lifestyle, or healthy approach for every single individual. I think definitely there will be some biomarkers and some of the digital biomarkers that will be generated. Having the AI working on this platform will be really great. I think that will be a great tool for Saudi Arabia that really we can work on and have utilization of the coming decade to come, working on healthy individual, but definitely healthy aging is part of them.
Yeah, thanks. So I would like to change the subject a little bit and continue with you, Saleh, because as Dean of a university, you have a role to do on training the next generations of health professionals. So I think we will all agree that there's a need to include this aging approach in forming the next generations. Are you doing something, or do you envision doing some changes in the curricula to include things like this? Or what's the situation at Kings Saud University?
Absolutely. Building capacity and creating capability is part of the global roadmap. And this is definitely one of the challenges that we need to overcome. First of all, the geoscience, maybe it is known in certain center in United States and maybe in Singapore, but now presence of Hevolution really have major fundamental role being a catalyst to push this forward. So what we have been doing at College of Medicine, Kings Saud University, that we have realized that the old dogma for healthcare or for medical curriculum, having one type of graduates, practicing physician, as one size fits all is not applicable anymore, because we know now healthcare is transforming quite significantly, but also science is transforming quite significantly. So we have to prepare physicians who are also scientists working on this area, because not only they will be a revolution for the science, but also the way that we practice medicine. So that we have started and we have embarked on a huge initiative looking at the whole curriculum. We are revamping everything, and we are allowing being under the umbrella of Royal Commission for Riyadh City. We are expecting to have an intake of different students from different parts of the world, but also the curriculum that we are trying to develop will have different tracks. So we don't expect graduating only practitioners. So we are graduating practitioner, but also graduating practitioner with technology flavor. We are also graduating practitioner with people working on biotechnology at large. Healthy longevity is part of the research line that we are really to develop capacity. And also we are accommodating now even one track, which is MD PhD. We do believe that we need many scientists, and scientists either with a degree or with training, and therefore we are creating MD PhD program. In addition that we have initiated a clinical investigator program, any clinical training program, either a residency and fellowship, that we are having 1 year of clinical investigation that they can work on the lab. So this is an important step. We do believe that it is critical, but I think this is part of the ecosystem. We need to fix the part of the rest and the remaining part of the ecosystem, which is that we need to have also a career path for those people, and we need to create a job for them.
Sure. Just because I would like to ask Jim, because you're also very, very interested in that part, and your vision is a little bit different. I mean, I think that what you're describing for KSA is fantastic that you're going that pathway. I mean,
sure.
The MD PhD program. Yeah, that's great. So, Jim, can you tell us a little bit about what you're...
Well, one of the things we found, again, the NIH has funded a program where geriatricians can be supported to do a PhD in basic science. Yeah. And we found that's incredibly popular. I think the current generation of trainees realizes that if this stuff works, and I hope it does, this could be as or more important than the discovery of antibiotics. This could change everything if we can target these fundamental aging processes and can treat things like Alzheimer's disease for the first time, or frailty, or improve health span. They realize it, and they really want, and we're getting the best of the best trainees wanting to do these programs. So I think we don't have to look for people. They want the programs. Yeah. We have to build them, and then we've got to have a place for them to work once they're
which is what Saleh is saying. Yes, definitely. All right, I think we're running out of time. So I want to thank our panelists. I want to thank everybody for listening to us, and we'll go to the next.
Thank you.